in my Good evening, everybody. I welcome you all to this webinar series on endometriosis, which is conducted by Indian Fertility Society SIG Committee, Endometriosis Committee, along in association with Tamil Nadu IFS chapter. And we are coming to the webinar series 3, which is the theme of this series is classification of endometriosis. As we all know, the endometriosis is a chronic inflammatory estrogen-dependent conditions where it has a very clinical and anatomical presentations. So classification is very important, not only to know the extent and the severity of the disease. This is very important to know the management, the surgical management, the fertility outcomes, and it's also important to have in collaborations with the other experts so that you have a better outcome and better communications. So though in a recent, though we have a recent advances in various classification like ASRM and EFS and even enzyme classification are there, but not in a single classification to tell us the difference of anatomic or the clinical outcome of this patient. So each one has its own limitations, strengths. And let us have a today webinar where each of these esteemed faculties will discuss on what are the various classification it pitfalls. So to bless us this with webinar today, I will really welcome our chief guest, Dr. Mridubhashini Madam, and our guest of honor, Ramini Madam, so that they are both are quite experts in IVF specialists and have contributed a lot to reproductive medicine. And as far as I know, Ramini Madam, she's a walking encyclopedia in endometriosis. So let us start this program. I request our IFS chapter secretary, Dr. Ajanta, to introduce our chief guest for today, Dr. Mridubhashini Madam.
It's my privilege to introduce our esteemed chief guest, Dr. Mridubhashini Madam, who has an extensive experience in the field of reproductive medicine. Madam has graduated from Stanley Medical College, Chennai. She had a PG training at University of Manitoba, Winnipeg, Canada. She was also former teaching faculty at University Teaching Hospitals in Winnipeg. And she was a former associate professor at PSG Coimbatore. And she is a former adjunct professor, Tamil Nadu MGR Medical University. And she is a teacher, guide, and examiner. And she has been the recipient of several prestigious awards and accolades. For the Sake of Honor Award from Rotary Club of Coimbatore, Lifetime Achievement Award from Tamil Nadu MGR University, Lifetime Achievement Award from Coimbatore OG Society and IMA Coimbatore, Best Women Entrepreneur Award from Coimbatore Management Association. She has also received Inspiring Gynecologist Award and by Times Group, and she has been recipient of ISAR Dr. Durusha Lifetime Achievement Award 2020, and also Lifetime Achievement Award by TAPISAR in 2022. She is Fellow of Indian College of Reproductive Medicine 2024. She is invited speaker at national and international conferences, and Madam is author of several publications. And also, Madam is member of ISAR, ESHRE, ASRM, FOXY, IME, and C2 Healthcare Panel, Coimbatore. We thank you, Madam, for being with us today and for sharing your wisdom and experience. May I request you to share a few words about endometriosis and your valuable perspectives on the topic, Madam?
Ajanta, I do not want to take too much time because we've only got an hour to listen to all our valuable speakers. But my congratulations for you for choosing this topic because it's given so much of development in the last 10 years. And I think a lot of us are sort of lost when you look at the basic pathophysiology of it, the classification of it, and especially when it comes to what do I do with it, whether it's going to be surgery or medical, when do you choose what kind of a thing? And everything starts with classifying it. And I think a lot has been said and talked about, especially in societies like Sooth Society, Society for Endometriosis and Uterine Diseases, based in Florence, Italy, and Professor Chaperon from France. And I'm sure a lot of it will be integrated in your talks that are coming up. I don't want to take too much of time. I'm delighted to be with all of you today, and I'll be happy to share anything that I can.
Thank you, Madam.
Thank you, ma'am. Thank you for those inspiring words. Actually, I know you from the time I'm a postgraduate. I've heard a lot of your talks in various conferences. Really, we just blessed that you are here to bless us and this part of this webinar. Thank you once again, ma'am.
All of you will do very well. Thank you.
Thank you so much. Now I request our guest of honor, Dr. Ramani Devi Madam. I think Madam, everyone knows Madam. As I already told, endometriosis is equal to Ramani Madam in the South. Madam was the president of Clean Up Fuji in 2024 and she was a vice president of Foxy during 2020 and she is ICOG Governing Council member in 2018-20. Presently, she is a managing director for Ramakrishna Medical Center and Janini Fertility Center at Trichy and Pudukkottai, and she was the chairperson of Endometriosis Committee, where I became the executive member. I have been continuing throughout that with Madam, and she was the EC member of SAFAG Infertility Committee and Scientific Committee of Endometriosis Society of India. She was executive member of Maternal Fetal Medicine of India and corresponding editor for Jogi and editor of for GCFR Guidelines of Endometriosis in 2017. And she has reviewed very articles like Jogi, Arjo, GPRI, and Jamar. And for awards, I think she has got a lot of awards to her credit, and she has a gold medalist in UG, PG, 5 Foxy Awards, and she has also got Abdul Kalam Award in 2016. And as far as I know, she has delivered a lot of talks, orations in most of national conferences, even few in international conferences. Madam has got Best Woman Doctor Award by Tamil Nadu State Government, IMA. And she has also got an appreciation award in 2021 and UNICEF certified master trainer award for violence against women, winner of Dira award for contribution to violence against women, and award for professional excellence in medical field by TNMC in 2024, and IFS master achiever award by IFS Society in 2024. And Madam publications have, as far as I know, she has written a lot of books and published a lot of chapters and contributed to a lot of national, international. Recently also she shared with me 2 of the best articles which is recent shared, and she has already written textbook for stud. So Madam, we are so privileged to have with you. Your experience, your talk really will inspire us. Over to you, ma'am.
Thank you, Dr. Chitra, for your kind words of appreciation. I am really happy to be here with all of you this evening on the most important topic which I love to, and it's close to my heart. That is exploring the enigmatic disease as on behalf of the SIG group of endometriosis SIG group of IFS. And the topic you have chosen, like you want to, Dr. Pallavi will be talking about the classification and the behavior, and Dr. Kanagalakshmi about the phenotypes of endometriosis and the extra-abdominal one by Meena Mahalingam. I think each talk is unique on its own because, as Madam has already mentioned, classification is very, very important. But starting from AFS, ASRM, and then upgrading towards the AAGL classification, Endometriosis Fertility Index, Enzymes classification, so many newer classifications have come out. But I should say none of the classifications are complete. And each one has got its merits and demerits. And we have to follow up the classification based upon the need of the patient. For example, if the patient is in need of fertility treatment, I think the classification, that is the in endometriosis fertility index, will be the choice. So it can guide both the doctors as well as the patient how they are going to manage based upon the post-surgical one. And enzyme classification is mostly for extragenital, as well as it will cover the entire thing. The deep infiltrative endometriosis as such, extragenital, adenomyosis, because these are not given in the other routine classification. Of course, we now have the AAGL classification. Then the next top is phenotypes of endometriosis. We have to understand not a single pathology is sufficient to explain endometriosis. Each type of this phenotype, for example, what we see in superficial endometriosis, the pathogenesis may not be the same as deep infiltrative endometriosis. And again, ovarian endometrioma. Ovarian endometrioma, now we know extra-ovarian, intra-ovarian, and again the pathogenesis gets altered, and so as deep infiltrative. Why this is important? Because not only for the diagnosis, and it may be presenting feature may vary with each disorder. For example, in endometrioma, the patient may not have any fertility, any symptoms. She can still be asymptomatic. Or in endometrioma patients, they can have associated DIE. So not a single phenotype is, usually it is a combination of phenotype. And the third topic is extragenital endometriosis. I think we are now coming across lot of extragenital endometriosis, especially from head to foot, and not a single organ in the body is freed, or it is to say that it cannot occur endometriosis. Earlier, they were telling that spleen was the only organ in the body which is not capable of getting endometriosis. But now we have recent articles to say that spleen can also have endometriosis. So from head to foot, from womb to tomb, I think endometriosis doesn't spare anybody, and it is extending its wings right from childhood up to the tomb. Like previously, we used to say that once when the patient attains menopause, the endometriosis will go off. It is not so. Even you can see fresh endometriotic lesions in the perimenopause and in the postmenopause. And it is not only that, it has got a link with the malignancy, as well as we have to understand a patient with endometriosis. We have to think widely, because it is no more a genital lesion. It has got an inflammatory pathology which will invade the metabolic things, and then it can cause cardiovascular problems. So, and as well as autoimmune disorders are very closely associated with that. So, I think if you know endometriosis, you will know the entire gynecology. This was what was written in the first topic of Thielen textbook on endometriosis, if I remember correct. Once it was endometriosis is confined only to one chapter, but we know that entire endometriosis needs lots and lots of things we need to understand. So with this, I wish Dr. Chitra successful series of endometriosis, and I wish all the speakers all the best. Thank you for giving me this opportunity.
Thank you, ma'am. Thank you so much for telling us so much insight into why the classification needed, what is necessary. I think you and Madam Madhusha, Madam, please stay back throughout and give a lot of inputs for this webinar. Thank you. With this, I welcome the chief guest, the guest of honor, all the faculty, the chairpersons, and all the delegates who have joined with us. So let us explore why the classification is necessary and how it is going to help us in the management. So to chair the first session, I'd like to call upon our faculty, Dr. Lata. She is a clinical director of Nova IVF Fertility Center from Coimbatore. Please, ma'am, welcome, ma'am, and kindly chair the session. And we have my friend Aarti. She is a managing director and lead consultant at Manu Hospital, Coimbatore. And she is a center in charge for CIMAR, Coimbatore. Presently, she is executive member of IFS Tamil Nadu and past joint secretary of IFS Tamil Nadu. She is a vice president of Cox Society. She has got Young Talent Award in ISA 2022 and Dronacharya Award in ISA 2024. So I request both the chairpersons to kindly introduce the first speaker.
My respects to Mriduvashini Madam and Ramani Madam. Good evening, one and all. As Ramani Madam said, we know the importance of classification of endometriosis. And now to deliver the first talk on endometriosis disease classification and behavior, I welcome Dr. Pallavi Chennamaraju. She is a consultant, Nova Fertility Center, Tambaram. She has done her DNB and 2 fellowships, one in reproductive medicine, the other one is in minimal invasive surgery. And her areas of expertise are IVF, ICSI, PGT-A and PGT-M, and recurrent implantation failure, male infertility, and fertility preservation. She has presented papers in ISAR conferences, and she is a member of various OB-GYN Society, Fertility, and Endogyne Society as well. So now over to you, Dr. Pallavi.
Thank you, ma'am. Thank you very much for your kind introduction.
I'll stop sharing. You can, yeah.
Yes. Ramani Madam, actually, a full my talk she told in 2 sentences. That shows her experience. So much of information in 2 sentences, she said. Nice to listen to, ma'am. 1 minute.
Yeah. You can go to share the slides, ma. The base, you got it. The base is a share. Just press on that.
Yes, ma'am. Yes, ma'am. I pressed it. 1 minute.
It will open to your laptop. Just see what are your presentation. Just click on that.
The slide is 1 minute, ma'am. It is not coming.
Yeah. It's okay.
Sorry.
Pallavi?
1 minute, ma'am. 1 minute.
Yeah.
Sorry for that.
No problem. Meanwhile, Ramani ma'am? Yeah, meanwhile, by the time she goes, you can give some inputs why these classifications are not able to come up to the standards of telling the extent properly, the anatomical thing, ma'am.
See, the most important thing is she has started. Okay, let her finish.
Okay, ma'am.
Give my input.
Yeah, you can slide share, ma.
Yeah.
Yeah, okay, done. You can start, Pallavi. Yeah, you can go to the slide share.
Yes.
Go to the slideshow. The third 4 year down. Yeah. Okay, fine.
Yes, ma'am. Are you able to see my slides?
Yeah.
Ma'am?
Yes, ma'am.
Am I audible?
Yes.
Ma'am. Yeah. Yes, ma'am. Today I'm going to start my talk with a small question like, does the stage tell us how disease behaves? So, to give the answer to the question, my first case, like Mrs. S, 28 years, she has a regular periods, no complaints, no dysmenorrhea. She had a normal flow. Even she doesn't have any dyspareunia. But she came for infertility because she's not able to conceive. They are trying for 2 years, but she is not able to conceive. So when I was done the scan, it showed like a 4.5 centimeter endometriotic cyst in right ovary and 5.7 centimeter endometriotic cyst on left ovary. Follicle her reserve was very good. And then second case, it was a 29 years, married since 2 years. She had a very severe dysmenorrhea and dyspareunia. And ultrasonogram showed there was no abnormality in the ovaries, uterus, but she had a severe probe tenderness. Laparoscopy was done for her, and it showed a small endometriotic spots over peritoneum, POD, and uterosacral ligaments. So these are two cases we are seeing like same disease but different phenotypes and then different behavior. In one patient, like she's having a typical almost stage 3 endometriosis, but she doesn't have any complaints except infertility. So second patient, she has a superficial endometriosis and a simple like a stage 1 endometriosis, but she is having severe pain. So, like always, we know the endometriosis has a different type of phenotype and different type of symptoms and different type of behavior. So, coming to definition to endometriosis, it is a presence of endometrial-like glands and stroma outside uterus. It is a estrogen-dependent and chronic inflammatory disease. Affects 6 to 10% of reproductive age women. It is up to 50% in infertility patient. We are seeing endometriosis. Why does endometriosis behave differently in different women? It is usually estrogen dependence because the estrogen behavior will be different with a different woman. And then it is a progesterone resistance because usually once progesterone is releasing, it suppresses the inflammation. But these endometriotic lesions are resistant to this progesterone. That's why continuous inflammation will be there, and it contains like a chronic inflammation. Some angiogenesis and a neuroangiogenesis because even small endometriotic spots present on the nerve endings and deep inside the peritoneum, they will have the severe pain. Even though it is a very less endometriosis, they will have the pain. And then again, fibrosis, it is particularly important in deep endometriosis. If they have the fibrosis and that distance of the anatomy, and then they will have the severe pain with a small movement of bowel and bladder. So one more thing is immune dysfunction. Immunity is an important factor. If they have the immunity good power and then have the resistance to that inflammation, they will have less symptoms, even though if they have a like a high stage endometriosis. So coming to ovarian endometriosis, it is a progressive ovarian damage associated with a reduced ovarian reserve. It may causes adhesions, and can it recurs even after surgery. So before going for surgery, we have to assess is really indicated or not. It is like it is having severe symptoms like a pain. It is no, we are not able to see the follicular growth. In case they are going for IVF, we are not able to retrieve the oocytes, then only you have to go for the surgery. Otherwise, better to avoid doing the surgery for endometriosis. If they have a bilateral disease, it has a greater impact on the ovarian reserve. Surgery itself can further reduce ovarian reserve. That's why we have to have a skilled surgical skills. Surgical skills should be very good while doing for the endometriotic cyst removal. So coming to deep endometriosis, these are the lesions infiltrate deeply into the pelvic structures. Common sites are like uterosacral ligament, rectovaginal septum, rectum, rectosigmoid, and then bladder, ureter, pelvic wall. It behaves behavior of this deep endometriosis is fibrosis and smooth muscle hyperplasia and dense adhesions. The distortion of organ will be there, so that's why like they will have the severe dysmenorrhea during periods, and then deep dyspareunia while having coitus, and then any urinary symptoms and bowel symptoms, because it irritates the organs like urinary bladder, ureter, and the intestine. It have the severe pain during the defecation and urination whenever they have the menstruation with the endometriotic cyst. So, infertility, we all know the main problem of endometriosis for infertility is because of distorted anatomy due to adhesions, and then a tubal dysfunction will be there. There will be altered tubo-ovarian relationship, and then inflammation. Because of this inflammation, altered peritoneal environment will be there. It impairs sperm and oocyte interaction, and it alters the fertilization capacity of the both oocyte and egg. So just because of inflammation, they will have implantation defects. These are the how endometriosis behaves. I have explained. Now we will go into the classification of endometriosis. Usually, any classification of disease, it should predict disease severity, and it should guide a treatment planning, whether we can go ahead with the medical management or surgical management. It should predict fertility outcomes. It should help in standardizing the research, and it should predict the surgical difficulty. But there is a problem with the endometriotic cyst is there is no single, as Ramani madam said, there is no single classification system completely captures the complexity of endometriosis. So coming to first basic classification of RASRM classification, it is based on lesion size, depth, adhesions, and ovarian involvement. It is a given stages like stage 1, stage 2, stage 3, and stage 4, depending on the involvement of the peritoneum, ovary, that is a superficial lesions are there or deep lesions are there, what is the size of the endometriosis, and then involvement of the posterior cul-de-sac obliteration, that is a partially it is involved or completely involved. They have given the points for each and every lesions for this, and then adhesions, how much enclosure was there, and then ovary right and left, flimsy or dense adhesions, and then fallopian tube right and left, whether they have a flimsy adhesions. Depending on that, they have given the score, and depending on the score, it is a given minimal to severe disease, like 1 to 5 score, it is a minimal endometriosis. 6 to 15, it is a mild endometriosis, and moderate endometriosis between the score will be 16 to 40. More than 40, it gives as a stage 4 and severe endometriosis. So, what are the limitations of RASRM classification? Was like a it has a poor correlation with the pain severity and fertility outcomes. It does not describe organ involvement and then deep lesions. But this stage does not necessarily predict clinical behavior. That means stage 4 does not necessarily mean stage 4 symptoms. So to give some more complementary classification, because that to include this deep endometriosis classification along with the ARSRM, it is a NGN classification. Basic NGN classification is added. It is a complementary to previous classification, that is RASRM classification. It is alone, we cannot take it as a proper classification for endometriosis. It includes image. This ARSRM classification, only during the surgery you can stage the endometriosis. But this NGN classification, it is included imaging of the pelvis, and then at the same time laparoscopy. Both together they have taken and given the classification depending on the involvement of rectovaginal vagina, one compartment, and B is a uterosacral ligament, and C is a rectum. They have divided, and the involvement of uterus, bladder, intestine, ureter also they have included. Only it gives information about deep endometriosis. Depending on that, A, B, C, F they have given. A indicates first rectovaginal and vagina. Depending on the size of the endometriosis, they have given A1, 2, 3 staging. Like that they have described in NGN classification. But after that, that latest NGN, latest 2021 updates they have given, it included everything like superficial, ovarian, and a deep endometriosis, and extra pelvic involvement also. It is included in this latest NGN classification. They have given the classification score also. These abbreviations like peritoneum involvement, ovarian involvement, and then compartments involvement, and then organ involvement, everything it is included in this NGN, latest NGN classification. In case of peritoneum endometriosis is absent, you can score it as a P0, and then mild to severe disease is there over the peritoneum from P1 to P3, you can mention in that. Then ovarian endometrioma also, depending on the size and involvement of the ovaries, they have a given 0, 1, 2, 3 stages. So even tubal involvement, tubal patency also they have mentioned in that, and adhesions around the adnexa, depending on the severity, they have given the T1 to T3 this thing. Like in case other organs involved like bladder, ureter, intestine, they have mentioned FB, FU, and FI. In case intestine and diaphragm involved, FD. So example like FB2 means bladder lesions between 1 to 3 centimeters. Though you can give the score like this. So peritoneum is involvement is there, depending on the size you can mention here P1 or P2, P3, depending on the size of the endometriotic spots over the peritoneum. And then ovary, depending on the size, whether left or right, and then ovary is missing or unknown, not visible, everything clearly you can write in one score this thing. Each and every organ involved, how much involved, everything it is included fully, completely it is included in the latest NGN classification. Tube involvement, and then disease lesions, and then whether it is a right or left, then what are the like organs involved, any other extra organs like lungs, nerve involvement, everything like depending on the location they have mentioned, and they have given this score system. Ideally, this all components involved in this latest NGN classification. So it is not limited to only deep endometriosis, it covers all disease. But exact site specific anatomical precision is there, and then it works with imaging. Usually with this NGN classification, you can preoperatively you can diagnose, and somehow like some classification you can get it where which part involved with the endometriosis, and then you can prepare for the surgery. In case if it is a ureter involvement, any stenting needed, any urologist you have to take the help from the urologist, any surgeon you should involve during the surgery, everything you can prepare. If you have some imaging, proper imaging images are there for endometriosis, you can involve them, and then you can go ahead with the surgical procedure. It always predicts the complexity, and then you can plan surgery very smoothly and without any risk during the surgery. But coming to the limitations of this NGN classification, it is a more complex and required expertise in imaging. This especially like images and laparoscopy both together we are taking for this classification. So if you want to have some idea about this endometriosis, you should have a proper expertise in imaging, like where exactly that location you have to find out what is the size of that, where it is involving, how much it is involving, everything. If you get proper idea by images, then you can plan according to you can plan the surgery according to that. But we are not routinely, not widely using this classification. If you have good expertise in the imaging and then laparoscopy, it is a very very good classification to have a good idea about the endometriosis. But then you can, now this like classification, you have diagnosed what is the present condition, what is the severity of the disease, everything you found with this classification. But what next? You have done the surgery, you have a stage you have given. Then our, as an infertility specialist, more important after classifying the disease, after doing the surgery, then you have to talk to the patient about whether she can conceive, what is the percentage of chances to conceive naturally or other ART procedures. Other than this, we have to explain to the patient. That is a main concern now. So after classification, you cannot just leave, but you have to talk to the patient in case she's an unmarried girl or she's a completed family. This is a different story. Completed family, then you can remove everything properly and then give a medical management like loprolide and then Egolex kind of things. So many things you can give. You can suppress the disease. But for to come to fertility, so you have to explain to the couple how much chances you have to conceive. So then the introduction of endometriosis fertility index came. So this is EFI index. So it is a prognostic score for the spontaneous and non-ART pregnancy after endometriotic surgeries. The total score given for this EFI 0 to 10, it combines historical factors of the patient couple or ASRM scoring and least function score included in this EFI scoring. This is a full like one chart of EFI scoring. You can mention everything and then you can discuss with the patient. So it included age of the patient, depending on the less than 35 years, between 35 to 90 years, or her female partner age is more than 40, or what is a married duration, that is less than 3 years or more than 3 years, or any history of prior pregnancy she had. And then what is the least function score, depending on the fallopian tube, fimbria and ovary involvement, either left side or right side or both side. That in case this is a if they have a good score, it gives a good success rate of natural pregnancy. So each component has its own scoring score, and then gives a outcome of surgery. So age of the patient, like she is very young, it gives a good score, and duration of fertility is a very shorter, it gives higher score, and previous pregnancy, this is more favorable to have a conception after surgery. If you do a very skilled surgeon doing without disturbing ovarian reserve, it gives good results. And then RSRM score, it gives the surgical disease burden, that particular. Then this is also gives a clue what is the outcome after the surgery. And then least function score, already I said, like function score. It is a 8 to 10, it is a good score, and 6 to 10, it is a intermediate this thing. But here it is gives only prognosis, but we cannot promise them that surely they will conceive if they have a good score. So that is very important with the endometriosis. You just score and discuss with the patient, and then give accurate, and then what treatment they can conceive, how much they can wait, what is the good options for them. So classification of endometriosis, like RSRM, how gives how extensive is the visible disease, and then it gives the stage, the disease burden it gives. Then that latest NGN classification, it gives where and how deep is the disease, and it gives the site and depth of the endometriosis. EFI gives what is the reproductive prognosis. It estimates fertility prognosis. So, to conclude, none of this classification, as correctly Ramani Madam said, none of this classification alone can completely explain pain, infertility, or the biological behavior of the disease, because endometriosis is a heterogeneous disease, different locations, different depths, different inflammatory environments, and different hormonal and molecular response will be there with the endometriosis. So, we should not treat the stage, treat the patient and the phenotype. Thank you very much for patience listening now. Thank you.
Chitra, ask for Madam's comment. Mridvashni
Yeah.
Madam. Yeah. Then I'll
Yes.
listen.
The chairpersons are there. Chairpersons, yeah. Yes, ma'am.
Yeah. Thank you, Dr. Pallavi.
Others,
Thank you.
what I have to say about
Thank you,
endometriosis may be quite different. And I think I'd want to wait for all three of them to finish what they're saying, so I can
madam.
finally sum it up.
Okay.
Yes, Pallavi, thank you so much. You have explained all classification in detail. As Ramani Madam said, each one of the classification has its own importance. You have given a good conclusion, and I'm waiting for our experts to give their opinion at the end of the session. Lata ma'am, please.
Thank you.
Thank you, Dr.
Thank you, ma'am.
Pallavi.
Thank you, ma'am. Thank
Thank
you
you.
for giving this opportunity. Thank you.
Yeah, yes, ma'am. Ramani ma'am, Rudra Sharmani ma'am.
No, Madam wanted to give at the
End
end.
of எல்லாரும் பேசினதுக்கு
Okay, yeah,
அப்புறம்
all the three speakers. Okay,
Yeah.
ma'am.
Okay.
Ajanta, please introduce the chairperson of second session.
Yes, ma'am.
I'll just share the slides, ma'am.
Yeah. It's my pleasure to introduce the chairpersons for the second session, Dr. Sumita Lakshmi. Dr. Sumita Lakshmi Balasubramanian. She has 20 plus years of experience, and she's a special interest in fertility, iris pregnancy, laparoscopy, reproductive medicine, and she's member of many societies, and she's also received CAM 2024.
42.
And it's my honor to introduce the second chairperson, Dr. Madhupriya. Dr. Madhupriya is Clinical Director and Senior Fertility Physician at SIG Endometriosis Specialty Hospital and Shri Fertility Women's Care. And she also has received several accolades and awards. She has presented papers and posters in many conferences, and she has publications in BJOG and IGCP. Madam has special interest in biological hair for pure ovarian reserve and also oncofertility. I kindly request both of you to chair the second session, Madam.
I request one of the chairperson to introduce her. Yeah.
Yeah, thank you so much for the wonderful opportunity here. So I would like to introduce the speaker for the next session. Professor Varun and obstetrics teaching and research. We look forward to Dr. Kananga.
Yeah, ma'am. Can you hear me, ma'am?
Yes, ma'am.
I am sharing the slides, ma'am. I'm just.
Yeah, it's visible, ma'am.
But I'm not able to see 1 minute. 1 minute. Sorry. Yes, ma'am.
Yes, we can see that.
Yes, ma'am.
Yes, ma'am. Yes, ma'am. Good evening to my guests and others. Can you hear me, ma'am? I can't see the...
Yeah, we can hear you. We can see your slides also. You can try to move the slides once. Press the next button. I think it's moving. I think so.
If I'm able to see the speakers, I'm not able to see the slides, ma'am. That's the problem.
No, again, what? Unshare it and again share it, ma.
Okay.
Yeah, you can share it again.
Now it is seen, ma'am? No.
No, yeah, no, you're not shared. Or can you mail it to me?
Yes, ma'am.
DRCHITRA. at yahoo.com.
Previously...
No, I think so.
Now seen, ma'am?
Yeah, it's seen, it's seen. You can go to the slideshow, yes. Yeah, you can start, ma.
Yes, ma'am. So, good evening to one and all, and special good evening to the guest of honors and the chairpersons here. So, my topic given is like peritoneal, ovarian, and rectovaginal endometriosis, how these three are different entities under one name. So, almost all the points has been covered by the previous speaker, how it presents, how it determines the diagnosis. But I'm going to give importance on each separate thing, how we have to focus on the diagnosis and as well as the treatment part. So why these three entities is important? So the learning objectives would be why these are different entities, how are we classifying with all under this one name, and how to apply the idea consensus to diagnose the three different entities, and finally, what is the medical and surgical management in this. So to understand the disease spectrum, we should know how these three types presents. So the peritoneal endometriosis present as a superficial implants on the pelvic peritoneum, whereas this ovarian presents as a chocolate cyst within the ovarian cortex, and the rectovaginal is being an infiltrative disease that is more than 5 millimeters beneath the peritoneum, and which involves all the pelvic organs. So each phenotype arises by different origin. So peritoneal, the most commonly known, the Sampson's retrograde menstruation by coelomic metaplasia. And the ovarian is by the invagination of the cortex by the implanted endometrium. That is, if at all, if there is a peritoneal adhesions between the ovary and the surrounding peritoneum, there occurs the inclusion cyst or the invaginations of the ovarian cortex where the endometriotic tissue bleeds during every cycles and the hemorrhagic cyst accumulates. Probably this is one theory by which the ovarian endometrioma occurs. And also with the rectovaginal septum, there is a metaplasia of embryonic remnants in those structures where there is a direct extension of the endometriotic tissue. So the key mechanism is there, it implants adhere and then it grows in the peritoneal surface, whereas in here it forms as a enlarged cyst with a chocolate content. And in the deep rectovaginal endometriosis, the smooth muscle and fibrotic hyperplasia around ectopic glands occurs. So how these classification systems arises? There are around 20 classification systems that are present to analyze and stage the endometriosis and to define the treatment for endometriosis. But 3 important classifications has little bit helped us in analyzing the patient and as well as categorizing the patient for a particular treatment. So the first one would be the revised ASRM classification, which classifies into minimal, mild, moderate, severe by giving a cumulative point score, representing the implants, adhesions, and the cul-de-sac obliteration. But as earlier said, it is like very simple, widely used, and it is mainly useful only for the research comparability. And it correlates very poorly with the pain severity of the patient, and it does not show the deep infiltrating disease presence. So this is the overall view of the revised ASRM classification staging. So next comes the classification, that is the Konig's classification, which formed the first initial step to categorize endometriosis in 3 different types, involving the peritoneum, ovarian, and the deep infiltrating disease. And this gives a clear pathogenetic phase, but yet it doesn't give the treatment part analysis. And also it doesn't involve the much of radiological involvement in this type of classification. So then came the complementary NCN classification, which maps exclusively for the deep infiltrating disease. And it clearly differentiates the area where it is present. So it divides the pelvic into 3 different compartments, A, B, C, and it also gives additional extra sites involvement as F. If it is FA, it is adenomyosis of uterus. If FT, it is tubal involvement, including the tubal patency abnormality. FB, it is bladder involvement. FU, it is urinary involvement. And FB, if it is bowel involvement. So this gives a standardized surgical description and the presence of ureteric involvement grading as well. And it improves reproducibility. And additionally, it can be used pre-operatively and post-operatively for the follow-up of the patient. So this is the classification system, POT A, B, C, F. And this is how the compartment is seen. So this is uterus in front and behind, that is the compartment A. It is craniocaudal axis of the involvement of the rectovaginal septum and the vagina. And the compartment B is the mediolateral axis involvement, which is uterosacral ligament and the pelvic wall involvement. And the C is the posterior compartment. The posterior compartment, which is behind the compartment A, which involves the rectum and the sigmoid. So this is the schematic. So with this, with the finding of the ultrasound as well as the MRI, this can be classified as a anterior, posterior, or the middle compartment, or is there any additional findings of adenomyosis, bladder, ureter, which is separately seen. So why this classification matters? So it clearly gives idea on the prognosis of the patient, where exactly the stage correlates with the fertility and outcomes, fertility outcomes more than with the pain perception of the patient. So the surgical planning, so the DIE mapping system helps in the multidisciplinary team involvement so that there could be a clearance of the disease as much as possible, and a shared language between the radiologist, the performing surgeon, and as well as the patient, so that they will be able to understand where exactly the disease is present. So to make this happen better, there came the ISUAG and the IDEA consensus. So it is a systematic ultrasound approach to a non-invasive diagnosis. So previously, to understand or to diagnose endometriosis, diagnostic laparoscopy was the first step of involvement, or first step of investigation itself to tell that, to see the patient is having an endometriosis. But whereas now with this consensus and with the proper ultrasound techniques, even without MRI, we can identify certain lesions and then we can start treating the patient so that there is no any delayed diagnosis. So this helped to build up the IDEA consensus. So what is the goal of this consensus is that it gives a standardized, reproducible, stepwise ultrasound protocol usable by any trained sonologist, so that transvaginal ultrasound becoming the first line imaging for any suspected endometriosis, reducing the reliance on the diagnostic laparoscopy. So it involves a 4-step approach. So the 4-step approach, initially we have to see the uterus and the adnexa to check out the position, mobility, presence of adenomyotic features, ovarian location and its mobility, and the presence of endometrioma. So what are the soft markers to be seen? Sometimes the ultrasound will be very normal, but yet we would strongly believe that the patient can have an endometriosis. So the soft markers would be the site-specific tenderness, ovarian mobility, direct or indirect signs of adhesions. Then the sliding sign, which we have to routinely practice in our daily day-to-day practice of doing a scan, where we dynamically assess the POD, the pouch of Douglas, whether and also the anterior and posterior compartment mobility, which I mentioned as per the Indian classification. Then the DIE mapping, that is deep infiltrating endometriosis mapping, by systematic search of anterior and posterior compartments for any nodules. So this is how we give the report: fixed retroverted uterus suggesting a posterior compartment disease. If presence of adenomyosis, asymmetric myometrial thickening, subendometrial cyst, fan-shaped shadowing can be present. In ovarian position, whether it is normal or adherent, it is having a bilateral kissing ovaries, which can be a key soft marker of pelvic adhesions. So the relevance of these findings would be adenomyosis and DIE frequently coexist and compound the system burden of the disease. So then how to do the dynamic transvaginal sliding sign? The gentle probe pressure while observing the movement of the anterior compartment as well as the posterior compartment. And the positive sign is free sliding. That is, if there is movement of the posterior structures, then the pouch of Douglas is free. It is out of any obliteration. If there is no sliding, that is, there is no any free movement, then it indicates that POD is obliterated, and it gives a strong predictor of having a posterior deep infiltrating endometriosis and the need for careful bowel evaluation in that particular person. So it would be a simple, real-time, highly reproducible, and it is definitely a central plan whenever we wanted to plan a surgical planning. So this structured ultrasound reporting describes each compartment explicitly. And if at all, if a nodule is present, we have to report the size of the nodule and from where it is present and how much it has infiltrated into the bowel. So we have to always document the sliding sign result also in that, whether it is present or absent. So this helps the surgical perspective to be planned very personalized for that particular patient. So now coming into peritoneal endometriosis. This is the earliest and the most easily missed phenotype, and most of the times the ultrasound will be normal. So as previously said, it is superficial implants of endometrial-like tissue on pelvic peritoneum, less than 5 mm depth. Pathological appearance, which can be identified only via laparoscopy. The common sites would be uterosacral ligaments, pouch of Douglas, plaid peritoneum, and the ovarian fossa. So may represent the earliest stage from which ovarian or deep disease can evolve. So this is a patient who has been done a laparoscopy merely for evaluation of the tubes and primary infertility, where such findings was identified. Patient is completely asymptomatic. So the diagnostic challenge here, the superficial implants are usually too small in ultrasound to be identified. Only the indirect clues can be taken up to identify that the patient can have a peritoneal disease like site-specific tenderness on probes or reduced ovarian mobility or subtle peritoneal irregularity. So the diagnostic laparoscopy would be the gold standard test for identifying this peritoneal endometriosis. So a normal ultrasound never excludes peritoneal disease, and we have to treat clinically whenever the symptoms are classically present. So naturally, the management part would be, the first line management would be the combined oral contraceptives or progestins. Depending upon the age, the scenario, we can categorize which can be the first. So then there would be the GnRH agonist and antagonist as second line, and NSAIDs for the symptomatic relief. Surgical plan would be, if the patient is symptomatic, then we would be planning for laparoscopic excision or ablation of visceral implants. And it would be mainly reserved for any medical failure patient or preferably for a fertility indication. So generally, excision is preferred wherever it is feasible. And the main problem is recurrence is always common in endometriosis. So definitely, whenever we plan surgery, we have to plan for medical in order to avoid the relapse. So the next is the ovarian endometrioma. This is the cystic phenotype. So its imaging and its importance in fertility always plays a role. So this endometrioma forms whenever an ectopic endometrium invaginates into the ovarian cortex. So it is anyway, whatever it is, if it is by revised ASRM or NSAID, it can be scored easily because it is evidently seen, and the cyst size and the adhesion extent classifies how far we are going to react for that. And 50% of the cases, it will be present bilateral and often signals more extensive pelvic disease if it is present bilateral. And bilateral adherent endometriomas fused in the midline, marker of a severe disease. So next, so this is sonographic points to identify the endometrioma. So unilocular thick-walled cyst, homogeneous low-level internal echoes, and absent internal Doppler flow. And often it is bilateral. And whenever we find any cystic lesion in a patient, we have to do a differential diagnosis to rule out between hemorrhagic cyst as well as any malignant condition. And this is a patient of bilateral endometrioma. It is the picture where the endometrioma has been removed, nearly 8 and 10 centimeter. I couldn't proceed for IVF because it was so large. So she had severe abdominal pain and as well as intense back pain. And the ovaries has been released from the adhesion as well from the left uterosacral region. But yet, immediately after the procedure, 2 months leuprolide has been given. And she had personal emergencies where she could not proceed into the treatment. And immediately the next month, once she got her cycle by her nature, she started having the back pain. So such intense is the disease in the patient. So this is, we have to differentiate between the other types of hemorrhagic cyst and malignance. So management is mainly depending upon the balancing symptoms and as well as the fertility desire in the patient. So medical would be hormonal suppression controls pain, but does not shrink the established endometrioma reliably. And it is main useful is either to pre-surgery or post-surgery for symptom control without any fertility intent. In regards to surgical management, cystectomy reduces recurrence versus drainage or ablation. So careful technique is needed. Cystectomy definitely lowers the ovarian reserve. So intense counting is needed for the patient as well. So with the guideline, individualize the cases if at all, if the size is more than 3 to 4 centimeter and there is pain or is there any suspicion in the imaging. Ablation or plasma energy can be considered in order to reserve the preservation in selected cases. With regards to rectovaginal and deep infiltrating endometriosis, the most symptomatic and surgically complex phenotype. So it is the nodular fibromuscular infiltration of more than 5 mm beneath the peritoneal surface. So the rectovaginal septum is a thin face between a preferential site for deep nodules. And recently there is a theory that there is nothing in the rectovaginal septum. It is mainly in the posterior compartments of rectum and sigmoid, which is getting extended into the rectovaginal septum. So the disease severity only it is showing, if at all, if there is involvement of the rectovaginal septum. Yet by NCN classification, there is a compartment of anterior compartment that is involving the endometriosis in the rectovaginal septum. So these are all in the dilemmas. Yet to know how severe the patient is presenting to us, anyway, we need to check what are all the structures is involved. So the common locations which is involved in deep infiltrating endometriosis is uterosacrals, rectovaginal septum, rectosigmoid bladder, and rarely the ureter. The symptom correlation, definitely the deep disease correlates better with the pain severity than the revised ASRM staging. So this is a schematic picture of showing bladder, uterus, and the rectum and the sigmoid. So here the lesion is seen in the rectosigmoid junction involving the rectum. And that is the ultrasound picture that is showing the nodules. So before doing an ultrasound, bowel preparation and all is not routinely required. Bladder should be emptied completely. And we have to systematically sweep between the anterior and the posterior compartment, that is from the bladder base, seeing the uterosacral, the mediolateral axis, and the posterior compartment as well. And if we see any nodule, it is better to size it, sight it, and if possible, we can measure it from the anal verge. Probably we should be knowing to, we should ask our radiologist also, if at all, if they find out anything, to give us a report as well. Because now we see very random reports, but maybe as a team, if we start seeing the patient, we'll be able to report this very particularly and very beneficially. So additionally, transrectal or rectal water contrast ultrasound improves the bowel wall layer definition whenever needed. So as I said, bowel involvement. So the number of bowel nodules, their exact location, how much the bowel circumference is involved, how far the distance is from the anal verge, and if it is a multifocal or multicentric disease pattern is present or not has to be identified in order to plan the surgical strategy. And negative sliding sign, it predicts the POD obliteration, and also the surgical implication and prompt colorectal team involvement as well as preoperatively, combined with the nodule mapping, gives a near complete non-invasive surgical map comparable to the diagnostic laparoscopy. So this is a case. This patient presented with distal ureteric obstruction, and she is a 40-year-old lady, nulli gravida, has given oocyte preservation. Embryo is not created since she didn't find a partner. She wanted to preserve uterus, ovaries, tubes, everything. She doesn't want any extensive surgery. Patient came with severe loin pain. She didn't even present with any pelvic pain, only left loin pain. Scan done, they gave a unilocular study, probably hemorrhagic cyst with the hemorrhagic component in the, I couldn't show the ultrasound pictures, the hemorrhagic component in the lower part of the ovary. Then since the patient presented with that complaint, anyway, the endometriosis, deep infiltrating endometriosis is the first point. So then I asked for MRI since ultrasound couldn't diagnose. They did MRI, and in that MRI also they were telling it is so large that it is compressing the ureter. It is just a pressure symptom. So MRI, then I couldn't get the film that day because patient also has to go to abroad, and she was also wanting the surgery early, and also patient doesn't want any extensive surgery. If at all possible, you remove the cyst. If not possible, no problem. That was though the findings are not correlating with the deep infiltrating endometriosis in the findings what they gave to me, yet I counseled the patient. I asked her consent, what all she needs and how far it can be done. She told whatever it is, extensive surgery is not needed. At present, please don't do it for me. Then did a laparoscopy. Then there was an intense adhesions, and definitely it is a deep infiltrating endometriosis compressing the ureter. Then urologist has been priorly informed about this. So he just did stenting, and patient is like post-operatively given leuprolide and digest. After 3 months, did ultrasound, the cyst regressed. The next plan is to remove the stent and further follow up. In this case, I need the seniors' inputs as well to do further. That's why I brought this case for discussion. And now the patient is doing fine without any pain, but stent is in situ. So this I want to emphasize because how far the team has to be interrelated to identify and what to be done and how to counsel the patient. So first line management, if at all fertility is not immediately continuous UCs, Dynagest or Janero channel locks. So this can reduce the nodule related pain, but rarely reduces nodule size substantially. reasonable to trial before surgery unless the red flag symptoms like bowel obstruction or ureteric compromise has occurred. Then with regards to surgical, always it is a multidisciplinary team to involve in this, involve the urologist, colorectal surgeon while doing the procedure, whether it is nodule shaving or disc excision or segmental bowel resection, all has to be priorly decided most of the time. And we have to explain the patient that it has a higher complication profile. It is mainly reserved for symptomatic and the fertility limiting disease. So what does the guideline says? So, for 3 different entities at a glance. So primary imaging in peritoneal is indirect signs only, whereas ovarian ground glass cyst, rectovaginal it will be a hypoechoic nodule. Best diagnostic tool would be laparoscopy in peritoneal. In ovarian it is transvaginal ultrasound. In rectovaginal we have to follow the ultrasound IDEA protocol with or without MRI. Fertility impact is variable. Ovarian is direct. Either we can try to preserve or do a surgery. Rectovaginal, it is variable depending upon the severity as well as the fertility limiting entity we have to plan. First line therapy would be medical in peritoneal. In ovarian, it is medical or cystectomy. In rectovaginal, medical first, then MDT surgery. So Eshrey says it recommends TVS as first line imaging. Laparoscopy no longer mandatory for diagnosis. So empirical medical treatment, hormonal therapy recommended as first line for pain, GnRH analogs. Fertility sparing surgery is individualized. Cystectomy is very, again, has to be counseled and taken part. And it supports, ASRM supports the clinical imaging as the best diagnosis pathway. So all towards the imaging. And for endometrioma more than or equal to 3 to 4 centimeters, surgical evaluation has to be planned. So the emphasis is individualized, patient goal-oriented decisions has to be planned. So fertility gives the fertility stands the first priority. So with regards to endometriosis and infertility, there is a causal link between endometriosis and infertility. So adhesions and distorted pelvic anatomy clearly impairs the fecundity. So medical therapy can be planned, but if at all, if it is effective for pain. But hormonal suppression for reducing endometriosis not be used. So do not treat infertility with hormonal therapy merely for endometriosis. So ASRMs. So with the fertility preservation considerations, so before endometrioma surgery, counsel the AMH decline, planned oocyte or embryo cryopreservation, a reasonable option before removing the endometriomas, or whoever is delaying the childbearing days. And ovarian tissue cryopreservation, it is like oncological indications. There should be a shared decision making between the patient and the consultant. Always a multidisciplinary pathway works best. So a sonologist, a gynecologist, a colorectal surgeon, and a urologist should be needed. Patient also is a part of the multidisciplinary pathway because finally sometimes they only take the decision of what they need. And common pitfalls to avoid: assuming a normal ultrasound that excludes the endometriosis, that is the peritoneal disease; draining rather than excision and endometrioma because high recurrence; skipping the sliding sign assessment because this misses the posterior compartment disease; operating on deep bowel nodules without multidisciplinary inputs. All these has to be avoided. And now it is like a pregnancy reduces endometriosis, soon become pregnant. That pattern of counseling is also, we have to refrain from that. So the take-home messages: peritoneal, ovarian, and rectovaginal are different entity. So 4-step ultrasound protocol we have to follow to identify the deep infiltrating diseases. The sliding sign is a simple but a powerful predictor of posterior compartment disease. And Eshrey ASRM both favor the early clinical imaging based diagnosis and individualized and fertility awareness treatments. Thank you one and all. Thank you IFS team for giving me this opportunity.
Thank you, Dr. Kanaga. That was indeed a very elaborate and a very, very interesting session. So I would just like to discuss about the case which you had explained, Dr. Kanaga ma'am. So was it a case of infertility? Because if it's a case of infertility, then I think it should be a one-step, one surgery concept, because evaluating, as you said very rightly, a very gold standard would be a transvaginal ultrasound, and diagnosing the staging and appropriate staging and pre-operative evaluation. The classifications would be good enough, whether to involve a multidisciplinary team and get things sorted out. So maybe I thought I should add that as an input to this case scenario.
Yes, ma'am. Yes. Ideal is a one-step approach only, madam. That's why I took time to counsel her. But the problem is she didn't find a partner. She is single. She don't have any support. She is not willing for any extensive surgeries because she may not have any post-operative support for her. Because if at all something happens, we need to put a colostomy, because every complications has been explained. Though the problem is, with expertise we can come out without any complication. We cannot assure the patient as well we would be without any complication. So in that scenario, that's why I didn't even touch anything, madam. Entered, we came out. Because at least to counsel the patient later, now she's mentally prepared for the extensive surgery. So probably after removing the stent, if at all, if she presents again with the symptom, we would definitely counsel her and plan her for the extensive surgery, madam.
Yes, Dr. Kanaga. So the take-home message should be like, there is no diagnostic laparoscopy as such. It's a one surgery. It's a complete surgery. So that should be the take-home message. Yes. Thank you. Thank you. That was a great presentation. Thank you, Doctor.
Thank you.
Yeah. Any other questions? I think our both guests will be talking at the end. So we'll go to the third session. So to chair this session, I call upon Dr. Chitra ma'am. I can tell simply she is a co-convener for SIG Endometriosis Committee for IFS. She was also a past secretary of IFS Tamil Nadu chapter. And I'd like to call upon Dr. Sashikala. She is a consultant at East Coast Hospital at Pondicherry. She is an IVF specialist who has a special interest in assisted reproductive technology, basic laparoscopic procedures, and infertility enhancing procedures. So I request Shashikala to introduce the speaker. Next speaker.
Good evening, everyone. So I'm going to introduce Dr. Meena Mahalingam, who's specially trained in urogynecology and microsurgery. She's master trainer in EMONC, faculty and organizing member in national and international conferences. She has more than 10 publications, including 5 original articles. And she has received scholarship from IUGA for attending IUGA conference in Italy. She has won Best Doctor Award from District Collector. She has won awards for scientific paper presentations and Dr. Durusha Award for Best Paper at IMS Con in 2026. I request Dr. Meena Mahalingam ma'am to present her topic.
Thank you so much, chairpersons, for the kind introduction. Thank you, Dr. Chitra, for having invited me to this interesting topic. And I would like to acknowledge Ramani ma'am for having shared our entire content. Thank you. So I would like to share my presentation. Is that okay?
Yes, Meena, please.
Is my slide visible?
Yes, Meena, it's visible.
So thank you. So my topic is extra abdominal endometriosis. So when endometrium leaves the pelvis. So I would be taking you through what extra abdominal endometriosis means, what is the prevalence, what is the classification which we follow, Markham classification, the different types, the gastrointestinal endometriosis, urinary tract endometriosis, thoracic endometriosis, abdominal wall endometriosis, which we frequently call it as scar endometriosis, and other infrequent sites. So as we know, the previous speakers has dealt in detail about endometriotic disease. Now, this occurs outside the usual pelvic or the peritoneal distribution, like extra-abdominal disease. I already mentioned the thoracic cavity, diaphragm, pleura, lung, chest wall, umbilicus, scar, groin, peripheral nerves, skin, subcutaneous tissue, skeletal muscle, the perineum. And in different types we have in thoracic means diaphragm, pleura, lung, bronchus, chest wall. Like abdominal wall means caesarean scar, laparoscopic port, umbilicus, inguinal area, round ligament, inguinal canal, rare sites as already mentioned. Now, the main clinical clue is cyclicity. So we need to know when the symptoms present or worsen around menstruation, there is a cyclical swelling which appear around that particular site, or there is a cyclical bleeding, cyclical chest or shoulder pain, when it is involving the previous cesarean or the uterine surgical scar, or whenever the woman has had a previous endometriosis, infertile women, or when we do not get any explanation for the symptoms by conventional investigation, we need to think of with a high index of suspicion of having an endometriosis. So the location may be unusual, but biology remains cyclical. So the distance rule, the frequency of the disease decreases as the distance from the uterus increases. Coming to the data, the prevalence data, 8.9%, that means to take 10% overall prevalence of extragenital endometriosis. Among that, the most common presentation is gastrointestinal tract being 32.3%. Next comes the urinary tract, which is 5.9%, and other sites like I mentioned scar, thorax, CNS around 61.8%. So 52.9% of them, they present first to the gynecologist. So we are the most important contact for them. The mean time of diagnosis is somewhere between from the presentation to identification is around 2 years. These are some sites which I have showed. Now, the Markham et al. Classification in 1989, he organized extrapelvic dissemination into 4 primary classes. So for easy remembrance, I like to say I love you. So I is intestinal, the most common adjacent pathway. So L is lung or thorax, that is the ascending systemic presentation, how it goes from the pelvis to the lungs. Class urinary tract, endometriosis, high risk for silent organ loss. And class O is other organs like cutaneous, nervous, and rare distant sites. And further staging relies mainly on the exact location, size, and depth of infiltration. Now, let us see what the gastrointestinal tract means to say. The prevalence is somewhere, I told 32%, somewhere between 3.8 to 37% of the patients. Mainly, it is seen in 93% in the sigmoid colon and the rectum. Remainder, 7% is seen in the ileum, appendix, and the cecum. Mainly, it originates from the Mullerian rest cells of the rectovaginal septum. They mainly are present in the anti-mesenteric border, that is the serosa and the muscularis. Coming to the mucosal involvement, it is very rare, meaning the functional extraluminal obstruction is more common than the luminal bleeding, that is melena. So the women can have dyschezia, that is difficult or painful defecation, chronic pain, tenesmus. Tenesmus is something like feeling to defecate, but there is an empty rectum, and intestinal obstruction. So how are we going to diagnose? The imaging for gastrointestinal endometriosis will be, first line is a transvaginal ultrasound. We need to look for the Indian headdress sign, or also called as moose antler sign. The rest of the imaging will be the high-end imaging like MRI or contrast enhanced CT or a barium enema. Any endometriosis, the final treatment is surgical management. Mainly if it is symptomatic. For asymptomatic patients, we need to wait and watch. So superficial endometriosis, a clean shaving is enough. For deep nodular endometriosis, a discoid resection or anterior rectal wall excision is needed. Severe, we need to do a segmental colorectal resection and later anastomosis. So this is a picture showing a post-op complication following the resection, a recurrence of bowel lesion which can happen, and temporary voiding difficulty due to nerve involvement. No, I already mentioned about the different bowel symptoms. So the patient can have chronic constipation, diarrhea, feeling a pulling down type of pain in the bowel, really painful bowel movements, severe bloating and trapped gas pain, rectal bleeding when the bowels open, or intestinal cramping, nausea, intussusception, and even sometimes it can cause a perforation. So as I mentioned, these are some pictures of transvaginal ultrasound showing the headrest sign, and the barium enema picture showing a severe pelvic endometriosis in this particular picture. The third picture showing, the second picture, we can see a stricture of the sigmoid, and we can see there is a dilatation of the proximal bowel loop. So here we need to remember the functional disturbances occur when the nerves are involved and mucosal involvement is rare. The multiple lesion can be satellite, which are common, or nodules may be located far away. It need not be a confined or a localized one. It can be a satellite lesion as well. Now, moving on to the urinary tract endometriosis, which I told is around 5 to 7%. The incidence is 0.3 to 12% of the total endometriosis cases. The first commonest among urinary tract endometriosis is the bladder endometriosis, which is around 80 to 90%, followed by the ureter endometriosis 10%. Kidney involvement is rare 4%, and urethra is 2%. In the pathogenesis is clearly disputed. It could be ectopic infiltration or a metaplasia of the Mullerian rest or direct extension from the anterior uterine wall following a cesarean section. So the iatrogenic trigger, usually 50% of the urinary tract endometriosis, the patients have a pelvic surgery like in the form of prior cesarean section. So they present with vesical endometriosis. The most common symptom for bladder endometriosis, the patient will have frequent urination passing continuously to the loop. There can be a pelvic pain or a lower back pain or blood in the urine, which can also give a differential diagnosis of Yusuf syndrome or a vesicouterine fistula. So we need to have a clear picture. The patient can have any of these symptoms, and there is a delay in diagnosis around 4.5 years. The signs can be, again, when we examine the patient, there can be a pelvic tenderness or lesions on the posterior cervix or vaginal mucosa. There can be adnexal mass or nodularity of the uterosacral ligaments, immobility or lateral displacement, or a tender pelvic mass, or they can have no findings. So this is a picture to show the transvaginal ultrasound, ideal screening showing a nodule, MRI with the greatest accuracy. We can see which defines the depth of detrusor muscle infiltration in this picture, and the cystourethropy usually confirms the finding. So what we generally see in cystourethropy is same color as the bladder mucosa, either a blue or a violet color, and it also helps to rule out malignancy. Urethral openings can also be identified so that it helps the urologist and gynecologist anticipate the type of urological procedure which needs to be performed for this urinary tract endometriosis. We need to differentiate from intraluminal bladder lesions or a urinary tract calculus or a simple urinary tract infection when we have such findings. So we can either go for a medical management in the form of GnRH analogs, progestins in the form of pills, intrauterine device, LNG-IUS implant, or a combined oral contraceptives only for symptomatic relief. The final treatment will be surgery, especially when there's extensive pelvic disease and hydronephrosis. Prior to that, we can give a medical hormonal suppression as an adjunct prior to surgery to prevent recurrence. And surgery mainly depends on the depth of invasion, location of the lesions, and superficial bladder lesions, usually treated with fulguration or excision. Deeper lesions involving the detrusor muscle require excision. Lesions which are close proximity to the interureteric ridge require a ureteroneocystotomy. So in isolated bladder lesions, sometimes we may do a local excision or partial cystectomy, either laparoscopy or laparotomy. So this is a picture to show a laparoscopic excision of the bladder endometriosis. We can see the catheter in the field and a ureteric stent being placed. The green one is the stent which is placed in the ureter. So it is important we place a double J stent when lesions are within 2 cm of the urethral meatus to ensure ureteral patency during the postoperative period. And it is important to do a cystogram routinely 7 to 14 days after surgery to ensure adequate repair prior to removing the urinary catheter. Now, let us move on to urethral obstruction and silent kidney. Urethral endometriosis, typically it involves a lower third of the ureter, that is a distal third, below the pelvic rim, and left ureter is most commonly involved than the right because the sigmoid colon directs the seeding. As we all know about the GI endometriosis, extrinsic and the intrinsic, again, there is a extrinsic type where 70 to 80% is because of adherence and external compression. Intrinsic in 20 to 30% because of invasion of the muscularis or the mucosa causing luminal projection. The danger is often entirely silent until obstructive uropathy leading to irreversible renal failure and renal damage. That is the only worrisome when we need to evaluate a ureteric endometriosis. So the definitive treatment will be extrinsic, will be ureterolysis or doing a segmental ureterectomy and placing the ureter into a neocystostomy in the intrinsic or the severe variety. Post-operatively, it is important we place a double J stent. Here we can see in the picture the ureteric endometriosis. The laparoscopically we have done a transected ureter with the stent and without a stent and the anastomosis. So classifying the ureteral endometriosis, the grade 0 is peritoneal endometriosis overlying the ureter. That is the extrinsic type. Grade 1 is retroperitoneal endometriosis with entanglement of the ureter but no dilatation. Grade 2 is dilatation of the ureter and or hydronephrosis without functional impairment. Urodynamic, no relevant obstruction. Grade 3 is urodynamically relevant obstruction with symmetrical renal split clearance in renal furosemide scintigraphy and normal total clearance. Grade 4 is urodynamically relevant obstruction with impaired split clearance in renal furosemide scintigraphy or impaired total clearance. Grade 5, as I mentioned, it's a silent kidney. So it can be a presentation as a silent presentation. There is no symptom, or they can present as dyspareunia, dysmenorrhea, pelvic abdominal pain, a cyclical presentation in the form of cyclic dysuria, microscopic hematuria, which is a hallmark, or a silent obstructive uropathy leading to renal failure. These are the diagnostic factors which we need to consider. Proper history, a cyclicity will be established. Doing a renal function test, TAS, TVS, MRI, urogram, MRI, CECT, IV urography, or isotope renography, ureteroscopy. So MRI has got a higher sensitivity than laparoscopy in ureteric endometriosis to differentiate extrinsic from intrinsic ureteral endometriosis. As I already mentioned, intrinsic endometriosis, successful ureteroscopic management has been reported. Ureteroscopic allows ablation with laser or balloon dilatation with stent placement when we identify an intrinsic endometriosis. But this may not be curative and needs follow-up with ureteroscopy, intravenous urography, and ultrasound to detect early recurrence. Extrinsic, I mentioned ureterolysis or a proximal ureteric endometriosis requires a segmental ureterectomy end-to-end anastomosis. Lower ureteric endometriosis usually requires a ureteroneocystostomy using a Boari flap or a ileal interposition or autotransplantation. Nephroureterectomy is done if renal function is less than 10%, and nowadays laparoscopy, robotic assisted laparoscopy is commonly performed for these conditions, such as the deep infiltrating endometriosis. In post-surgical follow-up, following surgery, we need to carefully think about symptoms of recurrence. So we need to take a regular history, physical examination, renal function testing, ultrasound surveillance for recurrent ureteric disease, intravenous urogram, MRI, if recurrence is suspected, and high index of suspicion is required to check for silent kidney loss. Patients need to be counseled for recurrence, and hormonal suppression for a longer period is needed. So this is the picture which I initially showed. These are the complications which are there. Genitourinary injury during hysterectomy for a benign indication when endometriosis was present. And major complications, a recurrence of ureteral obstruction, 7.4%, and ureteral or ureterovaginal fistula can happen, and hemoperitoneum voiding issues. So there is a limited place for medical management, and patients without significant fibrosis in combination with surgical intervention, we may have to do a medical management. Contraindicated in the presence of ureteric obstruction or hydronephrosis. And if the woman is childbearing age who desire pregnancy, we can plan for a medical management on postmenopausal women under close follow-up. So renal endometriosis, as I mentioned, it is less than 1%. They can present with cyclical hematuria, loin pain, and obstructive uropathy. Ultrasound, CT, MRI are helpful. They may be associated with pelvic endometriosis. It may mimic malignancy, and renal biopsy can help in the diagnosis. Smaller lesions are managed medically. Larger lesions require surgical correction, excision of the lesion. So teamwork is very important when we do a urogenital endometriosis, and we may need to take help of the gastroenterologist and the urologist. Now moving on to the thoracic endometriosis, which the women can present as catamenial pneumothorax within 72 hours of menses onset. There can be hemothorax in 14%. Here, the main pathogenesis is migration via the foramen of Bogdalag or lymphovascular dissemination, prostaglandin F2 induced alveolar spasm. So here, the diagnostic paradigm will be chest CT, which is most sensitive, ideally done during menstruation, or a bronchoscopy directed biopsies often fail. Breast cytology shows distinctive endometrial features. So we need to know what is thoracic endometriosis syndrome. Either it is a catamenial pneumothorax, catamenial hemothorax, or hemoptysis, pulmonary endometriosis, or a diaphragmatic endometriosis. So recurrent pneumothorax temporarily related to menstruation. Usually it is right-sided predominance. Recurrent frequently misdiagnosed. It can recur frequently misdiagnosed initially. In catamenial pneumothorax, within 72 hours of onset of menstruation, there is a recurrent pneumothorax. And catamenial hemothorax, uncommon manifestation. Most of the symptoms are non-specific. They may present with a bloody pleural effusion. They may take 4 years for the diagnosis. So this is a picture to show the CT chest with multiloculated effusions, nodular lesions of the pleura, or bulky pleural masses. So thoracocentesis, bronchoscopy are generally useful. These diagnostic tests also help rule out malignancy, infection, and other pathologies. CT chest helps to identify all these lesions, and there can be vague areas of bronchial wall thickening, bullous formation, or ground glass opacities. And CT also helps us to take a targeted biopsy, and imaging should be carried out. It's very important. We need to carry out during menstruation for higher sensitivity. Treatment, medical management has been considered the first step. Progestational agents, combined oral contraceptives, GnRH analogs are used. GnRH agonists are more effective in controlling recurrence, especially when used for prolonged periods as long as 1 year. Surgical treatment is the ideal treatment. So video assisted thoracoscopic surgery, that is called VATS, is the gold standard for surgical treatment of thoracic endometriosis, especially the catamenial pneumothorax, because it helps better visualization and magnification than at thoracotomy. Laparoscopy is needed to diagnose the abdominal side of the diaphragm. These can be fulgurated using bipolar diathermy or carbon dioxide laser. Larger endometriotic implants of the visceral pleura may be excised using sharp dissection. Coming to diaphragmatic endometriosis, which is 0.67 to 4.7%, it can coexist with deep pelvic endometriosis. The women can have cyclic upper abdominal, chest, and shoulder pain. Laparoscopic lesion ablation and minimally invasive excision are ideal. It is important to support them with post-operative hormone therapy to reduce recurrence. Why did we talk about right side? Mainly the peritoneal fluid circulation. There can be right-sided diaphragmatic fenestration. As such, according to the anatomical configuration or the hepatic barrier effect on the left, migration through diaphragmatic defects. These are the common reasons why the symptoms appear on the right side. So the women will come with cyclic right upper quadrant pain, shoulder tip pain, and chest pain. Now, moving on to the main, the iatrogenic seed or the scar endometriosis, which we call as the abdominal wall endometriosis. Classically, it's around less than 1%, that is 0.07 to 0.5%, 3 months to 10 years post-surgery. So how does it happen? Mainly, there is a mechanical transplantation of the viable endometrial cells into the fascia, the subcutaneous tissue during cesarean or episiotomy and lap ports. So characteristically, they present progressively enlarging cyclical painful nodule in a patient with surgical history. So the diagnostic track, frequently they are misdiagnosed as stitch granuloma, incisional hernia, lipoma, or abscess. So we need to think when a woman comes with previous scar, a painful scar nodule, cyclical enlargement, cyclical tenderness, cyclical bleeding, think of abdominal wall endometriosis or scar endometriosis. So this is a case series which we presented in the International Journal of Reproduction, Contraception, Obstetrics and Gynecology. The scar endometriosis, a mysterious painful scar. This study we have done in KGH along with Dr. T.S. Meena Madam, Nalina Madam, and our postgraduate Ashwini. So we had a case series of 22-month diagnostic gap was there between the prior surgery and the diagnosis. So we had a median age of 25 to 35. All the women had cesarean earlier. They had scar site pain. There was a firm nodule in 4 out of 5 cases, progressive enlargement in 80%, cyclical pain was present in 3 women. So it is important whenever we note a painful scar nodule in a woman with previous pelvic surgery, especially when symptoms fluctuate with the menstrual cycle, it demands immediate suspicion for scar endometriosis. So these are the differential diagnoses which we had thought. A stitch granuloma, again, a previous surgery will be there. Abscess, there can be or cannot be. Sebaceous cyst, there will not be any previous surgery. Incisional hernia, again a previous surgery. So the cyclical pain is consistently present only with scar endometriosis. Mass consistency can vary in the differential diagnosis. Firm in scar endometriosis. Stitch granuloma will be able to feel the stitch. Abscess, it will be fluctuant. Sebaceous cyst, again soft or rubbery. Incisional hernia, reducible. Cough impulse will be positive. So all these cases, the ultrasound was done. The next step was MRI. So these are the findings. So we could see there was a breach in the rectus sheath, the fascia and the muscle extensively involved. Surgical team actually has to keep ready a mesh reconstruction whenever there is a extensive defect. So the diagnostic laparoscopy was performed in all the patients, and to demonstrate there we could see adhesions and access for the coexistence of pelvic endometriosis. One case, the operative team identified the fistulous tract communicating directly with the uterine cavity. So what we did was a wide local excision. So complete surgical resection is the treatment of choice. The literature recommends at least 1 centimeter clearance margin around the lesion to prevent recurrence. So in this picture, you can see there is a 1 centimeter margin from the site of endometriosis. So facial repair can be done. Excision frequently produces a rectus sheath defect. Sometimes we may need to place a synthetic mesh or a biofilm so that there is no recurrence and the integrity will be maintained. The defect will be matched with the mesh. So these are the histopathological findings which we saw. The ectopic glandular tissue displaced into the abdominal wall. There will be presence of both glands and stroma outside the uterus. Definitely it confirms there is a scar endometriosis. There will also be fibrous tissue along with skeletal tissue, sometimes hemosiderin-laden macrophages. So this, all the 5 cases which we resected did not have a recurrence in our series, but when we took with other series, there was a 5% recurrence. Basically, it owes to the incomplete excision. So how are we going to break the chain? So use entirely separate instruments and needles for superficial abdominal closure. Never close the skin with instruments exposed to the endometrium. Site decontamination. Perform thorough high volume irrigation of the surgical field before abdominal wall closure to wash away the rogue cells. And physical shielding. Always utilize wound protectors and specimen bags where appropriate to physically prevent endometrial tissue contaminating the wound edges. So this is our study. So these are the pictures, intraoperative and MRI pictures. Always, whenever we cut the tissue, it will be an endometrial tissue. It will look like similar uterus, endometrial tissue within the specimen. So good surgical technique with proper care and removing functional corpus luteum at the time of hysterectomy, using high pressure irrigation, not using a sponge to clean the cavity, prophylactic hormonal therapy after hysterectomy, laparoscopic retrieving the specimens in endobags. So main thing, have a high index of suspicion, use high-tech imaging modalities, do a proper surgical management, follow-up is a must, malignancy is rare. Now, moving on to the different, this is about the cut section of the scar endometriosis. So these are the differential diagnoses which we have mentioned. Any painful abdominal wall mass in a reproductive age woman with cyclical symptoms, consider endometriosis until proven otherwise. So now different 5 minutes about different presentation. Umbilical endometriosis, Willer's nodule. Classically, they can present with umbilical swelling, pain, cyclical swelling can be there. Inguinal endometriosis, there can be painful groin swelling that increases at around menstruation. Differential diagnosis, we need to rule out hernia, lymph node, hydrocele of canal of Nuck, lipoma, soft tissue tumor. There can be sciatic nerve endometriosis where the women can have a cyclical sciatica, buttock pain. We generally compare it with the compression. So we need to rule out these neurological symptoms, progressive neurological deficit and severe disease. There are case reports of endometriosis of the brain, which is a rare condition where endometrial-like tissue grows in the brain or central nervous system. Generally, we diagnose using an MRI or a CT. The patient usually complains of severe headache, seizures, or neurological sensory changes, weakness, hormonal fluctuation. Treatment, generally surgical removal of the lesions with hormonal therapies to manage the symptoms. And lacrimal gland, the nasolacrical endometriosis is a rare condition, cyclic bleeding from the punctum. There can be crusted hemorrhage, hemorrhagic tissue in the nasolacrimal canal, dry eye symptoms like grittiness, itching, or burning. Diagnosis, high degree of suspicion, clinical correlation, imaging, biopsy, treatment, medication, surgery, or a combination of both. A rare case, hepatic endometriosis and its malignant transformation was reported, characterized by presence of endometrial-like tissue within the hepatic parenchyma. Preoperative diagnosis difficult through cross-sectional imaging like ultrasound, CT, or MRI. Histopathological imaging is the gold standard and treatment is surgery. Any endometriosis in different sites, surgery is the ideal thing. Pelvic nerve endometriosis, again, there can be any other nerves apart from sciatic, obturator, femoral, pudendal, inferior hypogastric nerves, and lumbosacral plexus. Their incidence is not ideally known. So here you can see the fibrotic nodule in the picture, cystic lesion, muscular atrophy, partial or complete encasement of the nerves in the imaging, MRI imaging. The patients can have pain, weakness, numbness, incontinence, paraplegia, which can be constant or catamenial. Early diagnosis is important to prevent irreversible nerve damage. So other rare sites are a Bartholin gland endometriosis, where a rare condition when we diagnose only by histopathological examination after surgical excision. Of the pancreas, a rare form, the patients will come with abdominal pain, pancreatitis, cysts, mimicking other pancreatic conditions. So imaging is important, and surgery, potentially hormone therapy to manage the condition in the to prevent recurrence. In men, again, few cases are reported in women, men who have had a prostatectomy and orchiectomy for CA prostate. So they were all on estrogen therapy. Site can be in the bladder, inguinal region, and abdominal wall endometriosis. Coelomic metaplasia is found as a cause. So recurrence, why there is a recurrence, depends on incomplete excision, persistent hormonal stimulation, disease severity, site, associated pelvic disease. So long-term follow-up is important. Malignant transformation is rare, but a changing, enlarging, atypical recurrent lesion warrants careful evaluation. Whenever we note a postmenopausal woman with endometriosis, we need to think of malignant transformation. So maintaining high index of suspicion, think beyond the pelvis. Whenever there is a cyclical symptoms occurring in any organ system, think endometriosis. Image, either MRI, CT, ultrasound. Eradicate iatrogenic risk. Multidisciplinary team, involve everyone, gynecologists. Apart from them, apart from us, urologists, thoracic, GI surgeons have to work as a team. So think beyond pelvis. Cyclicity is the clinical fingerprint. Normal pelvic scan does not exclude extrapelvic disease. Image the symptomatic site. MRI is valuable for deep, complex extrapelvic disease. Complete excision is important for accessible symptomatic lesion. Thoracic and neurological disease require multidisciplinary care. Thank you for the patient listening. Thank Ramani ma'am for having shared slides. Meeting.
Chitra?
Yeah, the chairperson.
Mridubhashini madam is there or not?
Yeah, ma'am, she's there, ma'am.
Yeah. Ask her to give her comments first.
Yes, ma'am.
Dr. Ramani knows that I always say something totally different. The endometriosis, the concept of what endometriosis is, how it presents and how it needs to be dealt with, has changed dramatically in the last 10 years. Okay. And there are international societies of endometriosis who've done a lot of work. And what is coming out of there is so practical. Okay. And I'll just mention the second speaker. She hit the right spot. Should think of endometriosis at 3 different stages: superficial endometriosis, ovarian endometriomas, and deep infiltrating endometriosis. SUP, superficial, OMA, ovarian endometrioma, DIE is deep infiltrating endometriosis. These are not 3 different diseases, it's 3 stages of the same disease. And the current concept is that endometriosis does not start just all of a sudden in a reproductive age group. It starts at adolescence. So the teaching that's going on now is, if you see an adolescent, a 16-year-old, 17-year-old, somebody who's going for a +2 examination, The parents bring her in saying that she's got severe pain during periods, and she often runs to the toilet to empty her bowel or a bladder during her periods. Think endometriosis, because they've gone back worldwide looking at the kind of presentation that all of us see most commonly is the OMA, whereas where you can't miss it. It's a reproductive age group woman who's got all the symptoms of pain and discomfort and all that. And besides that, a lot of them turn up to us for infertility. And you do a scan and you pick up this bilateral endometriomas. But if they've taken a whole bunch of them worldwide and gone back in their history, and they find that a lot of them had very bad dysmenorrhea in adolescence. So this is something that can be picked up much earlier before it becomes a bilateral endometrioma, in which situation it can be treated much more easily, and it can be even medically treated completely. And the second thing about surgery for all of endometriosis, now the consensus that people are coming to is the surgery for endometriosis should be done only once in a lifetime for a woman. And it should not be done again and again and again, which means that medical treatment takes the precedence and surgical treatment takes a backseat. Okay, and there are only certain indications. And I would also like to add that I don't think we should look at MRI as something too expensive and not to be done in endometriosis especially, because for you to define the stage of endometriosis, whether it's remaining as bilateral endometrioma or it's something beyond that, is there bladder, is there bowel, is there ureter, whatever is involved, you have to have the diagnosis before you enter the abdomen. You can think about oncology, it's like oncology. No oncologist this day would, even whether a government institution or any other institution, would dare touch a patient without their imaging being complete and proper. I think the same kind of guidelines should exist for endometriosis, because you need to know exactly what you're going to do and plan it adequately, which two of the speakers have spoken quite extensively about it. But I think that drawing up of a complete picture of how much this endometriosis is involved in that pelvis or abdomen, I think we have to have adequate imaging. So an MRI is not, exotic MRI is not something that is too expensive considering what you're getting out of it. So I think an MRI, if you're thinking that it's beyond the superficial endometriosis, MRI might be required for you to assess the cul-de-sac, the uterosacral ligaments, the ureter, the bladder, and the bowel. Okay, that's the only way of doing it. And then you can have your teams like we've talked about. But I think the whole picture of endometriosis and what we should be doing is changing dramatically. Like I said, the statement that is being made is, and most of us have given up doing ASRM classifications. Most of the larger units worldwide have given up ASRM classification because it doesn't give you any clue as to where you should be going and how you should be classifying it. You don't get all that information without entering the abdomen. After entering the abdomen, it doesn't make much sense for you to classify it. So the basic classification is what the second speaker was talking about. It's very good, which is, it's ending up with the starting with the superficial. I really can't say too much more about it, even though there's plenty of last 10 years of research on endometriosis when the conclusions that they're coming to. But, the statement that endometriosis should have only one surgery and that should be done preferably after their reproductive needs are fulfilled. Because once you enter the abdomen, the surgery that you're going to be doing may be actually producing more problems in terms of additions and reduction of their reproductive potential. That reproductive potential has to be looked after first before ablative surgery is taken on. Okay, so I really think if I start talking, it will be a very long talk. I think we don't have the time for it. And I think it's got to be a complete talk, starting with what endometriosis is and what the current concept is. So think endometriosis in an adolescent with very severe dysmenorrhea, even before she starts getting married or worrying about it. And the ovarian endometriomas are superficial lesions to start with. The endometrial cells, which are regurgitated, stay on the surface of the ovary and start growing, and then it invaginates. So what happens is when it invaginates, it takes a lot of the cortex with it. So the capsule is actually part of the capsule, ovarian covering. And it's also remarkable that underneath that ovarian cortex is where most of the follicles are. Most of the follicles are not in the substance of the ovary. They are situated just underneath the surface epithelium. So when it invaginates, a lot of the follicles go into the invaginated thing. So when you're excising an endometriosis, you're getting rid of a lot of the actual follicles. And therefore, there's always going to be a dip in AMH, a dip in antral follicle counts, and the dip in the fertility potential. So that you have to understand when you're operating on an endometrium as well. So endometriosis is a huge, huge, huge topic. And I think starting with the pathophysiology, because fibrosis wasn't added earlier. Now you can see a lot of people talking about fibrosis. Why is that important? Why is macrophage infiltration important? It's called the disease of macrophages. So inflammation is part of endometriosis. So if you just operate and forget about the inflammatory part of it, 50% of the endometriosis will recur within 5 years. Okay. So the recurrence rates after an endometriosis surgery is 50% in 5 years. So you have to cover them with medical treatment, even if you think that your surgery is complete. And there's a lot more things that can be said about endometriosis. Time is getting short, and I think already we've gone past the time that we're supposed to be doing. So I'll keep it for another day. Thank you.
Ma'am. Surely we'll invite you in the future webinar so that you give a talk for 1 hour. We'll listen to you and Ramani madam again and again.
Whatever. I'd be happy to associate with all of you. And you all did a very good presentation. And I think I enjoyed listening to all of you.
Thank you.
Madam, thank you for covering A to Z of endometriosis.
I didn't, ma'am. I didn't.
No, at least glimpses of what should be done from A to Z.
Yeah.
Okay. So I would like to give my input, the etiopathogenesis, why I said it starts from womb to tumors. The origin of endometriosis, as we think, even in the early adolescent, just the onset of telarchy is sufficient to trigger the endometriosis.
Yes.
Okay. How only certain people they develop is it is basically a genetic basis. Okay, that is why now the concept of neonatal uterine bleeding has come. So it reflects, it actually extrapolates the 10% of the female fetuses. When they did an autopsy, they found out that these fetuses had endometrial cells. So that means that is being extrapolated at an adult age. Then the next group is late adolescent, onset adolescent. There the etiology is transtubal spill. So that is why you get superficial as well as endometrioma. So now we should concentrate on identifying it earlier. Diagnosis should be earlier, and you should start the patient on medical management. That is the most important one, because all the societies, ASRM, ASHRAE, FOXY guidelines and SOGC, everybody are in favor of starting medical management as soon as the patient develops symptoms. And the commonest symptom, first symptom in an adolescent girl is progressive dysmenorrhea that leads to school absenteeism.
Yes.
So that one. So what I have done, non-invasive diagnosis is gaining more popularity now. Non-invasive means by the time the patient has got positive evidence in the ultrasonogram, it is quite advanced. But now there are techniques to find out indirectly the very early endometriosis, where some of the endometriosis experts are able to make out. They are even able to tell you the superficial endometriosis, like the blebs and the thickening, all those things they are able to tell. So other way is by subjecting them to non-invasive biomarkers. Non-invasive biomarkers, we have been talking about the CA125, CA19, and the interleukin, cytokines, all those things. But yeah, in future, microRNAs are going to become the non-invasive biomarker, and I have worked on this microRNAs. And actually what I have done was I have selected adolescent girls who are presenting to me with progressive dysmenorrhea and school absenteeism. Plus, I look into the family history, because the family history is 6.94 times higher incidence. So when these 3 points are there, I subject them to going in for a microRNA testing. Because microRNA testing is actually, it is, though it is under research setting, yeah, all the guidelines, SHA says practically we should not use it for diagnosis of endometriosis, but I think it only under research setting. Unless we produce more and more research, how are we going to get the answer? So probably by the next revision of SHA, I'm sure it will give importance to microRNAs. Some of the microRNAs are dysregulated and they are signature microorganisms for each disease, like like PMOS. So we have worked on that and we found out that severe patients presenting with severe dysmenorrhea, we initially started with 5 microRNAs, then we have narrowed down to 3, and we find out more 90% of the patients, it is very significant, and the sensitivity and specificity of this microRNA testing is beyond 90%. So that means not a single one, combining the clinical symptoms, family history, imaging evidence, if it is positive, or microRNAs together. Oh, so the combination of these biomarkers and the clinical symptoms, we can apply AI, artificial intelligence. So this will give us an idea of regarding the diagnosis. Not only that, how you should go about by management. In such a patient, we start the patient only with medical management. I am requesting all of you to start with Dynagest, not jump to the GnRH analogs, because now we have the oral GnRH analogs that are available and that is flooding the market, and there are pharma people are insisting that we must use. What is the time-tested drug? Dynagest is quite safe, and we have our own experience of using it beyond 10 years. Okay, then this GnRH analogs, we don't have any studies to say these drugs are useful, because beyond 2 years, we don't have the study. And what are the side effects and all those things. So I think 66 to 70% of the patients, they will respond to Dynagest, and some people with varying phenotypes also they respond. For example, for superficial endometriosis, it is effective. Endometrioma, definite pain relief, and on a long-term usage, there is reduction in the size. And for deep infiltrative endometriosis, it can help, but further, the deep infiltrative endometriosis people are found to have higher incidence of EGF receptors. So a combination of Dynagest or GnRH analogs along with gabergolin is found to have a very good relief, because this will reduce not only the angiogenesis, but it also reduces the neuroangiogenesis. So that is how it acts. And of course, regarding the surgical management, surgical management should be the end, as you have rightly pointed out, but there are definite indications for surgery. For example, even whenever you do an ultrasound, never fail to image the renal fossa, because I've seen young girls presenting with features of hydronephrosis because of ureteric obstruction. So simple ureterolysis, not that every patient will need a ureteric reimplant or ureteric anastomosis, because 80 to 90% of the ureteric obstruction is only periureteric, not intraureteric. So they will respond very well to ureterolysis. So then regarding Dr. Meena's talk, it's extensively it has been covered, and the main thing is all extragenital endometriosis should be handled only surgically. No medical management. Maybe for post-operative suppressive therapy, we can go in for like when you do a scar endometriosis, if the patient wants to postpone, give GnRH analogs. That will shrink. That will help us to perform our surgery in a better way with a lesser use of mesh. Okay, so that can be done. And then post-operatively also, we can suppress that with the oral medicines for some time, because to prevent the recurrence. I think anything else, Chitra? I think these are the points which came into mind.
One point?
Yeah.
I think very good points that you made.
Correct.
But the only thing, this teenager that both of us talked about, teenager with the severe dysmenorrhea, one thing you do not do is, she was talking about Dynagest, which is perfectly okay. One thing that you ought not to be doing is put them on oral contraceptives, which gets done all the time, okay? Because oral contraceptives contain estrogen and progesterone, but it's the synthetic estrogen, which is several times what the physiological estrogen level is, and it actually makes the endometriosis worse rather than better. So do not put them on oral contraceptives if your diagnosis is even possible endometriosis. Okay. So
I
oral
agree,
contraceptive.
madam. It has now Yeshre has put it in only at level B evidence. It doesn't have level A. You can put any sort of progesterone, even
Any progesterone is
norethistone is very good, especially in DIE cases. Norethistone is a very good drug. And another thing is
one of the suggested ones. Yeah.
yes, and DMPA also. DMPA, if patients are not affordable, maybe we can go in for a DMPA because there are evidences for its usage in as a contraceptive. We are using it for 2 years or 3 years. So
and supplement with some because bone loss are more common in DMPA.
yeah, that is why I'm telling. See, for when a contraceptive usage, when you are using it, we are having the same bone loss.
Yes, yes.
So that is why probably we can use it for a short term, 1 year or 2 years. And I'm very keen on putting all my patients post-operatively, especially post-hysterectomy. It's very easy to give them 3 doses. So anyway, we are going to supplement them with calcium and vitamin D3. And if needed, if they are put on a long-term basis, maybe I will add up this one, there is rest of us. What is that?
And therapy.
And alendronate. I used to combine them with alendronate. That also gives an excellent pain relief. Reduction in BMD is very much reduced. So I think whatever is concerned with this, and endometriosis fertility index, every operating surgeon should mark it. So because it will help us as well as the patients to understand how she is going to have her fertility in future. And another thing is this EFI will work only for 2 years. Following surgery, spontaneous conception is expected only up to 2 years. If the patient's age, but there are certain lacunae in this EFI. One is the male factor is not included.
Yeah.
And then the second one is AMH is not included. But actually, these two are the points to be criticized in endometriosis fertility index.
And
that's now important. We have another modified endometriosis fertility index without using surgery. Because when you look into the surgical factor, only 2 points are given in favor of the surgical factors. So that same thing can be applied by doing a detailed MRI plus HICO-C. That will give us an idea about the tube. So non-invasively, we can have the same endometriosis fertility index. That is a newer upcoming one.
Fine. Okay. Thanks. Thank you, ma'am. Thank you. Wonderful discussion. Both. Thank you, Mrudabhashini madam and Ramani madam. Thank you so much.
Thank you.
I request Dr. Ajanta to deliver the vote of thanks.
On behalf of Indian Fertility Society and SIG Endometriosis Committee, I sincerely thank our experts, Dr. Mrudubhashini Madam, Dr. Ramani Devi Madam, for their valuable insights and perspectives on endometriosis. I also sincerely thank our chairpersons and speakers for their wonderful presentation. I sincerely thank all the delegates for the enthusiastic participation. And thank you all for being with us today, and have a wonderful evening. Thank you.
Thank you very much.
Thank you once again, ma'am. Thank you, madam.
Thank
I
you,
request
madam.
both of you to attend any future webinars and just try to give them more inputs. It's good to have from experts all the time, ma'am. Thank you.
Okay.
I really,
Thank you.
yeah, from my side, really want to thank Ajanta. Really, she was able to get the speakers, chairpersons. It was wonderful hearing to all of you new people. Thank you so much for being part of this IFS. I hope we have more collaborations in the future.
Sure, madam. Thank you so much for the opportunity,
Thank you.
madam.
Thank
I really thank the IFS admin team, Santosh, everyone for providing this thing. Thank you all. Thank you, ma'am. Good night.
Thank you.
Thank
Have a
you.
good evening. Thank you. Thank you.
Thanks, Meena. Thank you.
Thank you, Chitra. Thank you, Ramani ma'am.
Thank you, madam. Thank you, ma'am.
Thank you, Ajanta.